It's up here. As you can see, the screen is reversed. We can see it correctly here, but it goes through. It's a see-through screen, so we didn't anticipate that. But we do have presentations that are available for you to follow along. It's actually online, and there's some seating up here if someone would like to come and see it from the screen up here. First of all, we did introduce everyone at the last meeting, so in the interest of time, because this is going to be a lengthy meeting, we won't do that today. I think most people around the room at least have been acquainted with each other. But one of the things we'd like, the first thing I got to do, just as a housekeeping thing, is you have the minutes in your book. So I'm going to ask for a motion and a second, if somebody so desires. I've got a motion and second to approve the minutes from the March 13th meeting. Is there any discussion? Hearing none, all in favor say aye. Aye. Opposed, the same. The ayes appear to have it. The minutes are approved. First thing I'd like to do is say that I did meet with the, we had a tentative, just informal discussion on some of us yesterday about regional meetings. So before we actually get to the presentation today on PEIA, let me say that there will be a meeting of the public, what are we calling that committee? The Public and Legislative Outreach Committee next Thursday at 2 p.m. in the Secretary of State's office, the Governor's Conference Room, we call it. But I can tell you that we looked the state over and believe that at least 11 meetings need to be held around the state to try to get within fair geographic areas of people for public comment. We hope to complete that schedule through May, which is a pretty aggressive plan. We also plan to have one, probably two, public hearings that will be done in Charleston, but they'll actually be over the internet so that people can watch and respond. Our tech guys know how to do that. So we'll do that and we'll announce that date. We also do already have a website that's up and running, taking public comments, some of which are already being made. So we know the public's already weighing in on the PEIA question. Today, what we would like to do, what we're going to do, is we're going to look at PEIA, exactly some of the details of how the PEIA plan is put together, how it works. We have Ted Cheatham with us today, the director. He's going to make a pretty lengthy presentation, and all I can say to you is this, is I know that this can get pretty detailed, but I speak to the task force and say it's our responsibility to understand this plan, to struggle with it, know what it is, and some of you are insurance people and you'll understand the concepts that are being presented. For others of you, it may not be as familiar, but it's our intention to know what it is, because as we know, has been said by many, fix PEIA. Well, you got to know what you're fixing before you fix it, or to understand exactly what it is. And it's got a lot of dimensions to it, as you will hear how this plan is kind of got some uniqueness to it relative to other insurance offerings. So without any further ado, I'm going to turn it over to our guy that's there in the spotlight, our director, Ted Cheatham. It's all yours.
Thank you. Is this on? Great. Welcome all of you. Thank you for taking on the task of what you're doing. We appreciate all your input, and we appreciate your assistance in trying to make this better for the citizens that we serve. As was said, this is going to be a long and grueling day. I've got over 100 slides here to go through. Some of them are just for reference, but I've left you a book that is going to be a great reference book for you to have through the course of the task force. I've also included a shopper's guide, which lists a lot more detail about benefits, exclusions, eligibility requirements, etc., which you can peruse at your own pace. Hopefully you're going to see out of this thing that we are a fairly well-run agency. We are a good fiduciary of your funds. We don't make any money, we don't make any profit, we don't profit share. We get money in and we pay claims. And I think you're going to find we try to do that very well with the tasks we're taking. The final thing I want to do before I go through this is tell you there are a ton of numbers in here. And most of you are going to be just fine with the story I'm telling you, but there's 10% of you out here that are what I call number crunching nerds. And you're going to try to dig into these numbers, and you're going to look at a table and you go, well, you said 120 million over here, and this one says 105. I don't want you to get distracted by that. We do know how to count at PEIA. Some of these charts are incurred data, some are paid data, some are paid data. Some don't include retirees. Some don't include this. Some data is a 6-month period, some's a year period, some's 3 months that's been extrapolated to a year to compare it to another year number. Don't get upset with the minutia of something that looks inconsistent. I assure you it is. We can give you any exact number you need. I just don't want you to get distracted by numbers. Listen to the story, please, and the message we're trying to give you. With that in mind, we are off. Who are we? We are a state agency founded by statute, Statute 5. This is important, folks. We are not an insurance company. We are ERISA exempt insurance plan or payer plan. We're not regulated by the Department of Insurance at all. We are regulated by a 9-member board. 8 members are defined by statute. That was changed a couple of years ago. And it's chaired by the Secretary of Administration. These are the duties of that finance board. The bottom line here, the finance board is charged with giving us a 5-year plan. In theory, they could come to me and say, Ted, here's $1 billion, work it out. And as long as I stay within that $1 billion, they've done their duty and I'm fine. I have never embraced that concept. We bring the finance board in. Premium and benefits are so tied to finances that we discuss all those with the finance board. They go out to public hearings and they get comments on all the changes. So they are very much more involved than the core need for their job is defined. I would be guilty not to talk about some of the statutory highlights that drive some of the changes or the things that happen at PEIA. First is the Employee Retirement Income Security Act. We are exempt. That lets us waive certain federal requirements, but we still have to comply with the Affordable Care Act. The 80-20 premium you hear all the time. If the legislature appropriates money, the statute wants us to spend 80% comes from the payor or the employer, 20% comes from the employee. That means in theory, the legislature and the governor's budget to PEIA sets premium levels on aggregate at 80-20. There are some exceptions to that rule, and the legislature has used it on 2, 3, or 4 past occasions, and I will point some of those out to you later in the presentation. We are required to do 3 public hearings, once in each congressional district. That goes on in November this year, so I'm asking the task force nicely, please do something by September so I can take out the public hearing what we want to do. Dependent coverage is required under this law. I've talked to a lot of people saying, well, let's just not have spouses be covered by PEIA if they have coverage elsewhere. Statute clearly states dependents, including spousal dependents, are eligible to be covered by PEIA. If you want to do something else with spouses other than what we tried to do last year with 80-20 and the pay plan we presumed, we probably will need to change the statute. The next one is the Omnibus Health Care Act. What this act basically says is that if a provider in the state of West Virginia accepts a PEIA patient, they cannot balance bill the member and they must accept the fee we offer. This is a huge boon to PEIA. It is the only one I know of in the country, and you did that years ago, and it has been awesome, but it's also got its shortfalls, which we're going to talk about today. You may lose this if you privatized us, but that is an important piece of legislation for PEIA. Everybody talks about why we're salary-based. There is in the statute that the finance board may base premiums on ability to pay, and they have done that, and it's clear in the statute that they can. It also states that they are able to provide a retiree subsidy as they see fit, which they've also done, as you see coming up. Non-state agencies, we have over 600 non-state agencies. A non-state agency is a quasi-government entity. States, cities, municipalities, bus routes, water districts, as long as they're eligible to participate under that code definition, they can come into PEIA. So that's them, and we treat them kind of as if we're an insurer. 600 agency, we provide them insurance at a set premium, and benefits. And we'll talk about them in a minute. And finally, the retiree issues. I don't want you to forget about retirees. Currently, we all know about pension liability, right? Well, there's another liability out there for us at PEIA, and it's called Other Post-Employment Benefits, or OPEB. When I took over PEIA in 2006, that liability was $8.4 billion. Thanks to the work of the legislature and the PEIA staff, that liability today is $3.4 billion. And some of the things we've done to do that is we stopped retiree subsidy for health insurance. That's what creates the liability for anybody hired after July 1st, 2010. This is an important safety tip for you. There are 35,000 people working within the PEIA system that have been hired since July 2010. That's why the OPEB liability is staying so low, because nobody can get it. The next one, the net 3% cap set by the Finance Board. This is a Finance Board duty that they've done a heavy lift. They set a fixed amount of money per retiree and have said that will never grow more than 3% per year. And today, that subsidy is about $154 million for retirees. We've managed it very well, but they are capped at a certain level. They can only grow at 3% a year, and that was done by the Finance Board. That also keeps that OPEB liability in check and keeps us at that $3.4 billion. The other two that are mentioned there is the sick leave conversion. I'm going to talk a little bit about sick leave later, but we did stop sick leave conversion for anybody hired after July 1st, 2001, and it went to 50% down back in '88. I'll talk more about sick leave in a minute. That's some of the statutory highlights I have, and I guess I would ask you if you could hang with me to the end, because it is going to be a rather long talk. If you're still awake at the end, I'll take your questions, and I'll be here as long as you want me. This is what we do. Every agency's got to have a mission statement. This is ours. And let's talk about really what we do in life. This is very busy. You're probably going to need to look in your books for this. But I was talking to Delegate Bates the other day, and Delegate Bates said to me, Ted, you probably ought to tell us who you are. Nobody knows who you are and who your staff is. So let me tell you who runs PEIA. And unfortunately, I have to start with me. I am an Army veteran. I have 2 undergraduate degrees, one in personnel management, one in finance. I have an MBA from Troy State University, and I have a law degree from Whittier College School of Law. And yes, if you ask, I am a member of the California Bar. I've been in this business for over 30 years in all aspects of health benefits. That includes all the ancillary products, life, health, dental, legal, short-term, long-term disability, as well as what you know today is health care. I've done mergers, acquisitions, and turnarounds, and run health plans in all sectors, which includes Medicaid, Medicare, and commercial. But enough about me. Let's look over here at the member services, the left side over here. These are the people that answer phones, do our eligibility, and do mailroom operations. Our mailroom is virtually paperless. We get a lot of paper, but all of it is image to be worked on. So we try to maintain a virtual paperless environment. This section is run by Charlotte Stover. She has a Master's of Science from Mountain State University and 28 years in Health Benefits Administration and Claim Payment Administration. The clinical department in the middle there, the clinical department, takes care of our appeals, our wellness programs, our pharmacy contracts. By the way, Member Services also does our Humana contract and our Health Smart claims payment contract. The clinical department is run by Felice Joseph. She has a degree in pharmacy from WVU, 15 years as a retail pharmacist, came to PEI in the late 1990s. Great asset for us. Budget and finance is run by Jason Hott. He's also a graduate from Marshall. Been in the business 23 years as a state employee, started in auditing at the state of all places, and has been with PEIA since 2001. They do all of our billing, our OPEB accounting, our receivables, collectibles, accounts payable. They said don't do that. There we go. Communications and outreach is run by Jan Powell, excuse me. She has a BS in journalism from WVU and 30 years experience in the communication field for health plans. And then legal, we have Bill Hicks, who's been with state government and the private sector for over 17 years working in the healthcare field. So I think you see a rather strong management team sitting at PEIA that I would take to any commercial environment we had. It's a good, strong, educated, and talented group of folks. I want to spend a little time for a minute. Now is the time to talk about privatization. I know it's going to come up. People talk about it. It bubbles all the time. Should we privatize PEIA like we did to workers' comp? Now's my chance to talk about it. I just told you what we do. I've got less than 60 people. I typically run between 50 to 55 people at PEIA. If you wanted me to be an insurance company, I'd need at least 250 people to manage this plan. I don't have it. I have no actuaries. I don't pay a claim. I don't have a pharmacy contract. I typically don't have any medical contracts. I don't do any of those things. We contract out everything. We are a contract management company. And even if you outsource this product, you still need somebody to manage those contracts, do those audits, do all the things that we do to make sure things work. So I just wanted to pass that on to you, that we are virtually contracted out for almost all services. There's not much we do in-house other than contract management. Now, could you outsource some of the things we do, right? So could you outsource customer service, for example? And my response is flat out, yes, you could. Yes, you could. I have about 7, 8 people sitting over there answering the phones every day. We take about 350 calls a day. Could you move them to HealthSmart? The answer is absolutely. But I'm still getting to 350 calls a day, and I still need 10 people to answer them. I'm just going to transfer those costs to HealthSmart. Anything that we do here, primarily, that we could outsource, you're not going to save a lot of money to move it because the job still has to get done. That's the point I wanted to make. Yes, we can lower the cost of state government, but you're going to increase the cost of the contracts you manage to take over those services. But that's my discussion on privatization, right or wrong. Just wanted to let you have that, know where I was. We have a three-legged stool. This is what we try to balance at PEIA. And these are the things you're going to need to help me look at as part of the task force, right? We have our providers we have to pay. They have to continue to want to take our patients. We have to serve those patients and members that we serve at the state government. And, no offense, this bill is paid by the taxpayers of the state of West Virginia. So please keep all those in mind as you're looking at solutions for the task force. Off to the money. Here we go. I say we're a $1 billion plan. I say we're a $1 billion plan because it's a nice, easy number to use. We're actually $921 million, but $1 billion sounds a lot better. And if I say I need a 5% next year, you can multiply $1 billion by 5 and get $50 million. If I say my drug spend's 25%, you can multiply $1 billion by 25 and get $250 million. I use $1 billion because it's a nice, easy, round number. This is how it's broken out, and you can see how we shuff. We also have 3 risk pools. We have those state agencies. By the way, state agencies, we consider them state employees, higher ed, and all the school districts. We consider them state employees, that 3 group. We have non-state agencies, which are those 600 quasi-government entities I talked about, and we also have the retirees, both the non-Medicare and Medicare retirees. That's the 3 risk pools that we manage. This just breaks out for you the actives. You can see how the actives break out in terms of 52% of our actives are now county boards of education. And again, 60%, if you look here, 60% of our, 60% of our agencies, 16% of our population is in 600 agencies. That's a lot of administration costs for those non-state agencies. Just off to the money. We break out our money into 2 sectors. We break it out into the state fund employees, about 647, as you can see. And again, at 80-20, there's your 80-20 at work. And then the non-states. The non-states, again, are a completely separate risk pool. They're in their own product by themselves. They're rated separately. No state money on the active side is used in the non-state pool. I must emphasize that enough. I get asked that a lot. No state money goes into the non-state pool at all on the active side. The retirees, I generally will tell you, the subsidy does vary by pre-65 or non-Medicare to Medicare retirees. Retirees and non-state agencies are not subject to the 80-20 rule I talked about earlier. These people are not. The takeaway here is that the retirees are getting about a 30 to 32% subsidy on their premium every year. That subsidy is being paid by active employee premium. You're going to have to look at this on your own. This is the PEI's local fund for the upcoming plan year. Just wanted to show you what we looked at. If you look down here, right here, OPEB funding, West Virginia RHBT funding, PAYGO, that is the retiree subsidy coming from the non-states. Think about this. Yes, the non-state pays a premium. 20% of it is used to fund our retiree subsidy. So the non-states are contributing. And listen, I love the retirees. I'm not saying anything bad. I'm trying to give you facts. If we did not subsidize the retirees under this method, we could lower active premiums by 20%. So we start comparing national averages. How does PEI stack up? That premium could be lower by 20%. But we'd have to find another way to finance them, by the way. The money's coming from somewhere. This works as good as any. All right, this is the active state fund. Again, you can see that. If you take a look, you'll see that same RHBT number right down in there, that PAYGO. Also for this, I'd like to point out up at the top right in the middle there, this is that $29 million right here that the legislature gave us, the governor gave us, saying we're going to freeze PEIA. That's the $29 million. And if you notice, there's about $8 million in the top line going into premiums. I can explain to you why that is later, but let's just say it's got to go there to get us to 80-20. We're slightly off the 80-20 calculation, so some money needs to go there to get us to 80-20 into the premiums, primarily to the employer side. The employer's not paying enough. Also, to the left of this $21 million, and I'm sorry I'm having a hard time seeing the laser pointer, right in here, you'll see that $30 million transfer. Several years ago, the legislature gave us $30 million for 5 years to help shore up PEIA. That's the $30 million you gave us for a 5-year period. It's going to run out in a couple of years. This is the non-Medicare retirees. Again, you'll be able to see the OPEB funding in there if you look. And then this is the Medicare retirees. And again, take your time to look at this. I just want to make sure you had the financial plan in some detail for background to look at. This is the retiree leave issue that I talked about. So if you're hired before 1988, you can use your days of service or your sick days to convert to fully paid, 100% paid premium or 50% paid premium. You notice we've got about $12 million a year that the state is paying to cover benefit costs, premium costs for retirees, and they get it at no cost. Every time we do a rate increase, retiree doesn't pay it, state entity pays it because it's being sick leave conversion. And I don't want to leave you with that. Here's a page that will tell you how you can calculate your sick leave benefit. And again, you'll recall that we changed it after 1988. And higher ed also has a slightly different formula for converting sick leave than normal. I'd be remiss if I don't get into finances with the OPEB plan. Again, other post-employment benefits. All the work we've done is going to get the OPEB plan fully funded around 2034 to 2038. I think we're doing a great job. Let me tell you how it is funded. $30 million a year goes into the OPEB plan from the old workers' comp fund. That's an indefinite transfer of $30 million dedicated specifically to the trust for OPEB. Additionally, the Finance Board has made the commitment not to touch the corpus of our trust, which has just under $1 billion in it. So any investment returns on the corporate trust are put towards OPEB. They are not used for operational expenses. So you're seeing 30 to 50 million additional dollars every year going to fund OPEB. And you'll see that as we get a little later. So 30 million guaranteed coming in, plus any investment returns, if we have a positive return, goes to fund OPEB. And last year, I think we put $80 million into OPEB, over and above the 30. That might not be right, 80 or so million. And just so you know where our money is, that's left over, it's right here. We are required to use IMB and the Board of Treasury, BTI, and you can see our trust is just under $1 billion at $952 million sitting in the bank in long-term investments, growing every year to get to that $3.4 billion funded level. How have we done for you? Well, only three of the last 15 years has PEIA not beat national averages of trend. I think that's pretty good. And the years where it happened centered a lot around the Affordable Care Act, which I will talk about later in this plan. I think we've done a pretty good job for you beating national trends. When Delegate Jenkins, Senator Jenkins at the time, swore me into PEIA, he said, "What should I expect from you?" And I said, "What you expect from me is what you'd expect from your stock market broker. And that's to try to beat the market every year." And I think I've done a pretty good job of doing that for you. If you compare premiums, which is all we can, because remember our premiums are funny with the 80-20 rule, they're set odd. So you can't track premium related, you need to track our claim cost. If you look at our claim cost to national premium trends, you can see we also outperform national premium trends. So how do we do that? What do we do for administration? That's the next piece. As I said to you earlier, we're not a high overhead piece of business. If you take this and privatize it, you can ask the man over there, I don't want to put him on the spot, or you can ask these insurance guys down here what an insurance company makes on administration. And having run several insurance plans, I guarantee you it's not 3%. We're running at 3% admin on this PEI plan. And what it looks like when you break it out into dollars. That's where we spend your money for administration. The big one is the contract with HealthSmart up there of $10 million. Now we've got to do a HealthSmart commercial. HealthSmart is our TPA. I asked them to put some numbers on what kind of stuff they're doing for us as part of the contract we have with them that we audit and monitor. You can see they process over 2.5 million claims, PEIA, and roughly $2 billion in billed charges. Remember I told you we're a $1 billion plan? I'm already starting to show you the problem and the advantage of the Omnibus Health Care Act. $2 billion coming in, $1 billion going out. We'll talk about that some more as well. And you can see the things they do for us in denied charges and other denials as they're processing claims. We have a great turnaround, and we've got a pretty high auto adjudication rate. 65% is pretty good for the industry. And then we have other basic management plans with them. So if you take a look at our maternity management plan, we're also getting a 12% return on that investment with high-term, high-risk pregnancies. So that's a little bit about HealthSmart and what we do there. Let's talk about benefits. We have 4 plans today. 4 PEIA plans, 3 plans with the health plan of the Upper Ohio Valley. 10 different salary tiers. The deductibles, the out-of-pockets, and the premiums all vary by salary tier. The retirees, we have 2 plans available for them, and they are based on years of service, with the highest subsidized rates coming in over 25 years of service. And that, again, is the 4 plans that we offer. Clever names. Now we start to get a little busy slides. My takeaway for you here is to notice that the majority of the population is sitting in Plan A. This will also show you little to no coverage in Plan C and D, and you'll see roughly what the average plans are there. This slide coming up, I love this slide. This is a great, great slide for you. Let me point out a couple of things that are interesting. On the left-hand side, these policies. Notice this 20 to 30 range and where these policies all lie. Most of them, 84% sitting in Plan A. Look at the top. We had all that conversation last time about total family income and why these would go down. Notice that these 500 people, 600 people, they can't affect enough money change to affect these guys down here at the bottom. It's just an interesting distribution that you'd like. This over here on the right shows you where they fit in terms of single and one or two children, or child or children, and then family coverages. Interesting chart I think you'll find useful as you go through the task force. But that's some takeaways from this chart about where our population lies. This takes that 20 to 30,000 tier structure where everybody is and just lays out some benefits for you on what our standard benefit package is, deductibles, copays, etc. Again, we'll let you look at that on your own. There's really two main tiers of coverage that's globally there set up for you. And then just here's a little more over here, and we're going to talk a little bit more about out-of-state coverage, because as you look down here at the bottom of the chart, you'll see down here out-of-state changes, right? And we're going to talk about that later. We have a lot of out-of-state issues. I'm going to show you why, and I'm going to talk to you about what we've tried to do over several years to manage that. But this is also the deductibles, et cetera, that you can see. Take this one on your own. This just shows you how we've tried to migrate people through the plans over the years. We slowly tried to get the plans to 80-20, the tiers to 80-20, and price them correctly to move people so we're not subsidizing between plans, but we still do. Plan A is still subsidized at the moment, but we still, this just shows you where people have moved over time. Don't need to spend much time on that one. And this one, it talks about how people have changed demographically over time and where they've moved. I would point out to you, we have an older population. I think this average age is at 47. I think a commercial plan runs somewhere between, somebody can help me out there, but somewhere between 39 to 42. So we indeed do have an older age population with pretty high disease state. And then one more time, we've got premiums by plan and coverage on averages for you, just so you'll have them. And don't forget, one more time, I'm going to keep harping on it, 20% of that premium is used to subsidize retirees, okay? Don't forget, 20% of that premium. This is for you to talk about what we've done the last 3 years to affect our population. Oh, that's what we did in 2016, that's what we did in 2017. You can look through that on your own, and 2018. 2018 was some significant changes. Finally, we'll talk about deductibles and out-of-pocket changes. Everybody asks me, especially Dale and I have this conversation routinely, and Delegate Nelson as well. What, Ted, if we were to change the deductible by $100, what would that cost? That's what this chart is for, just a little layout for you. And if you look at the first column over there, it says basically, if we were to raise the deductible for a single by $25, and in our plans the family is twice that, so the family would be raised by $50, and we raise the out-of-pocket by $150 single and $300 family. If you look at the very bottom, that would cost PEIA about $5 million. So when you're running through the task force and you're thinking, boy, I bet they're complaining that we should lower this deductible. We really need to lower the deductible. It's just too high. They can't afford it. You can go to this table and say, well, if I were to lower the deductible by $500, roughly what would that cost be to PEIA? So that's what this table is for, just a reference. I'm always asked how we compare nationally. Let me caveat this slide, and let me caveat this comment again one more time. You are going to hear this when you go to public hearings, and I just want you to be prepared. The
The people that are insured by PEIA, we have a good stable population, have been insured a long time. They truly believe they're underpaid. And when you say to them on the outside, at IBM, at BB&T, look at this plan. Look, it's got a terrible deductible. It's got twice the premium. What are you complaining about? The response is, look, I make $30,000 a year. I made $30,000 a year for the last 10 years, and you're raising my premium $20, and I can't afford it. That's really what they care about. You're changing what they have today. I did want to compare by national because I've been asked. But understand, it's a very weak argument for the population we serve because they really don't care what's going on nationally. They care what's happening to them in West Virginia. But this is compared to Siegel data nationally. And please understand, we're based on salary tiers. They're not. These numbers could be reduced by $25 for a single and $50 family if you're tobacco-free with PEIA. We have a tobacco incentive, so you could lower these even lower. And don't forget, we're covering the retirees. They could be lowered by 20% if we were not using this method to subsidize retirees. And then this is the family tier of the same chart. And those notes are again in the bottom just for clarification for you. For another source, we did a Milliman survey. This was given to me by an insurance professional. Just threw it in the packet so you'd have it. This shows average regional plan benchmarks of deductibles, co-insurance, and out-of-pocket maximums, as well as benefit structure. So you could compare what's in the local states compared to PEIA and the commercial environment. And then some more of that slide, making it a little bit bigger. Didn't fit on one page, so you can look at the deductibles. I would say generally our out-of-pocket is much lower than you'll find on the outside. Then we should talk about what is the real value of our plan. So we've asked our actuaries to say, hey, how do we stand? How do we stand compared to the exchange, the gold, silver, platinum plans? How do we stand actuarially on a plan? This next table tries to demonstrate that to you. And it demonstrates what we've changed. You look in 2010 at this lower range over here. It's we paid 92% of the cost of care under that plan. Today, it's gone over to 84%. That's the actuarial change over these last 8 years. The other thing I think I'd like to pass on to you is look at the difference in the structure from the top at 84% down here to 79% at the top tier. That's a direct reflection of the fact that we're salary-based and that the benefits, deductibles and out-of-pockets, are also higher as you go up in the tier. So you can see the actuarial value. And again, I've made the comment to people, if you hit the 60 to 70,000 range, this is probably about where we're starting to compete with global products. If you're below that, you're probably better off. If you're above that, you may be slightly worse off. I mean, that seems to be a good point for looking at where we are because of the salary-based structure. And then the next slide is just more data for you having to do with the maximum out-of-pockets and what they've done over the years. And you can see the out-of-pocket, for example, in the lower tier has gone from 800 up to 1,800 over the last 8 years. The biggest jump happening in FY18. As I said, last year, we made a rather significant change because there was not a lot of funding last year. But we didn't do it all ourselves, folks. I told you, although we're not an insurance company, we are subject to the Affordable Care Act. This is the effect the Affordable Care Act's had on us. You'll notice over the last several years, $77 million has come from the fact that they took away our maximum out-of-pocket limits that we had for years. There's also fees that are required us to pay. So between those, that's been a lot of money. And, wait, that's not all. There's more. Other benefits that came along with the Affordable Care Act also ran another $15 million a year, looking at our other plan issues. So it's not all us, it's not all the state. I just want to make sure you understand we are affected nationally as well by things that go on. And as much as people believe, and true, that the consumers have been very much valued and added to by the Affordable Care Act, somebody has to pay for it, and that's our part. So who are these people and what's the eligibility? That's the next topic of discussion. First, what do we do to manage eligibility? We did an eligibility audit about 5 years ago, to make sure that people were eligible for PEIA. I believe we saved about $12 million and kicked off somewhere close to about 10,000 people that were on the plan ineligibly, if that's a word. Since that time, we require anybody that enrolls has to either have a birth certificate proving they're a legal dependent, or they have to have a marriage certificate to prove they're a spouse. Since that time, we just started because we don't know how to do this. We can catch them coming in. What happens when they get divorced? We started a divorce audit 3 years ago. To date, we've kicked off 2,200 people who have managed to try to keep their spouses on the plan illegally. 3 of them are currently being prosecuted by the AG's office for fraud. So we are trying. And right now we're doing a Medicare validation audit with a company called SSDC. They are bumping our eligibility against the Medicaid database for our Medicare and non-Medicare retirees to see if any of them are qualified for disability, so that we can get them off our rolls and get them onto Medicare, which saves us about $1,600 a month, should we be able to get them moved. But our enrollment is going down in the state population. The state population is indeed decreasing, as you can see in the top line, and the retirees are increasing. When I arrived at PEIA, there was about 36,000 retirees in the Medicare plan. Today there are over 50. I'm going to show you that charge later, but that group is growing. For your pleasure, not by alphabetical order as it probably should be, but by volume of people, these are how many people we insure by county. So now you can ask the question, in Lincoln County, we have, 1,354 employees. And all the way out there in Doddridge, we've got, what does that say, 328. Just for your reference, cool stuff. And the next 5 pages I'm going to zip through our enrollment by state and county out of state. And, we've got about 10% of our population that lives out of state, most of them retirees, but we have about 600 people that are employees of the state of West Virginia that live out of state, out of contiguous counties even, out of state. All right, I won't bore you with this one. That's just for your reading pleasure. Now, where do we get our money? This is where I want to talk to you about premiums. And this was important for the legislators, I think. As I talked about, if you go back to that first slide, I talked about the state, and I showed you that $29 million was sitting up at the top, and $8 million was sitting on the top up there, and I said because of 80-20, and the other 21 of the 29 was down here. It has to do with the funding in terms of general revenue and special revenue. All right, so this shows you the breakout of general revenue and special revenue. General revenue comes truly from the state coffers. Special revenue are agencies like PEIA, DMV, OT. In theory, those people raise their rates to pay for our increases. The non-general revenue, special revenue agencies have to have an allocation from the state to help pay for our increase in revenue. So if it comes through the formula with general revenue and special revenue like it's doing at the top, for the 80-20 match, we actually will bill the special agency money and we'll bill the general agency's money, and that's how we get that match of 80-20. If you just give us money outside the formula, it's all special revenue, and it doesn't affect the 80-20 rule, and that's a little bit of issue. So if I need $100 million, to make easy numbers, 80% of that has to come from the state, or $80 million. $20 million will come from the employees. Of the $80 million that I asked for, and I go to the governor or the legislature and say, I need $80 million, they then will take 65% of that, God knows what that is, $50 million, and say, that's general revenue. So although I'm asking for $80 million, and $80 million is technically coming from the state, only 65% of the $80 million will actually go into the budget as special revenue. That's for the legislators, just so you understand. And that's what this chart is designed to show. Another fun, exciting facts for you. You're going to hear when you go to public hearings that we never used to have to pay for health insurance. We traded health insurance benefits for salaries. You're going to hear it, and I'm going to tell you this slide proves it's true. 1995, employees did not pay a cent for health insurance. It's the way it is. I've taken you back to 95 and showed you what's happened to the premiums over the years. This is just for your fun, so take a look. I'll just run through them real quick. And let me take you to the last page, which I hope I'm there. I'm having a hard time seeing through the light. So if you look in July of 17, you can see they've gone from 0 back in 1995 to right there in the middle, $56 on that salary tier, $50 on that salary tier, $56 in July of 2017. Now I had to know because I'm curious, right? So I went out on the internet and I found that $1 in 1995 would be worth $35 to $34 today. So 35 to 34 of that 56 is just inflation, as you'd see for cost of living. The other thing I would caveat to you is we all know that health insurance has been trending faster than normal inflation for many years. So seeing that we're only at $56 is not too bad. For our financing of the reserves, this is our reserve history. Let's walk across the top, and you can see what our PEIA reserve has done. It's gone up, up, up to as high as $230 million in 2014, and we spent it back down to get where we are today. And take a look at the PEIA OPEB reserve there on the second line. That's the funding that we've done for you for OPEB. That's how we've grown to $916 million. And remember on the other slide it was 952. I tell you, don't panic. It changes. It's all good. The next line, you look at the additional funding from West Virginia. That's the money that's been allocated to us from the legislature. So if you look across at 2010, they gave us $27 million. 2013, they gave us some, and then in 2017, you see the big $81 million. Now, these two numbers here, actually 2012, 2013, and 2014, all those numbers were outside of 80/20. Remember I told you they were outside of 80. One of them was to fix an out-of-pocket maximum. One was to fix another minor plan benefit issue. So really we didn't have a lot of money from the legislature in those years. That's the story you've been hearing about, and that's where we actually spent down our reserves to get where we were, that we needed that $80 million in 2017. Now let's go to the claims and the provider side. So I've given you the money inside, right? This is the money coming in. These are the sources we get it. It's percentages by employee, employer, retiree, retiree, general revenue, special revenue. Now we're going to talk about what we do with it. So, in-state reimbursement. This is a big part of that three-legged stool, right? So hospital reimbursements, these are anecdotal, they're not factual. I get these from people like Mr. Litnanchin over there in the Hospital Association. Our reimbursement rate to the in-state hospital is around 30% of charges. Right? We pay Medicaid rates to the hospital. Now let me explain this one to you because this gets spookier. And I don't want to delve on it, but if you were to go to a hospital CEO and say, who's your worst payer in the state? Buffy's going to say, PEIA, okay? And here's why it even looks worse than it is, because I'm telling you we pay Medicaid rates. Here's the problem. It's called the Medicaid swap. We loan $7 million to Medicaid every year. Medicaid raises their fee schedule to the providers to get a 3-to-1 federal match, because they get a 3-to-1 match, thus generating $28 million. We give them 7, They generate 28, which goes right to the hospital's bottom line. Nice deal, right? To offset my $7 million, I lower my fee schedule. Joe, close your ears, please. By about $10 million. So I make a little bit of a profit off the deal, so to speak, but I lower the fee schedule about $10 million to make up my $7 million loss. I'm being as transparent with you as I can. I'm just letting you know it worked. So if you look at that deal, it looks like we pay much less than we do to the provider, but we're paying really about Medicaid rates because of the Omnibus Healthcare Act that I told you about later. Okay? The professional reimbursement is about 100 to 111% of Medicare. I would tell you that a commercial product is probably paying at least 135 to 180 to 200% of Medicare. I would tell you, if you ask any of the hospitals or the doctors, they're going to tell you that PEIA is the lowest payer in the state of West Virginia. And I want to tell you here today as task force members, as I've said to Joe Letnachin on years, because I always have somebody ask me, why don't we just lower the rates to the hospital? I think they're there, guys. I think that our rates as low as they can get to the hospitals. And I thank goodness that they're willing to take our patients. We talked about lowering the fee schedule to doctors a year ago in a 3-year step, taking it from 111 down to 100% of Medicare. I started getting letters from all the professional associations saying, don't do this, we're going to stop taking your patients. So I want you to be careful when you talk about provider reimbursement. Next is I've got this comprehensive care partnership I'm pretty proud of. It's been going on for several years now. It's got, oh, I'm sorry, before I get there, I'll get to comprehensive reimbursement. This is the out-of-state issue. So out-of-state, we contract through HealthSmart. We don't contract, remember, with HealthSmart for Aetna Signature Administrators is a national contract. It averages 42% off charges, as you can see, but we also maintain some direct contracts. Not us, HealthSmart on our behalf. Sometimes we help negotiate. Sometimes they do it for us. For example, we have an individual contract with Cleveland Clinic because our contract with Cleveland Clinic is better than Aetna Signature Administrators' contract with Cleveland Clinic. So we do our own contracts, and also people end up in hospitals where we don't have contracts, and we do negotiate individual deals for care as they arise. That's what happens out of network. Keep in mind, that's a pretty good rate for a national network at 42% off charges. Now the Comprehensive Care Program partnership, we've got about, as you can see, 17,000 members in several of these groups. And of course, I'm very happy that that Buffy over there, Beth Hammers, is part of that program. It is a capitated program. What does that mean? It means we pay a monthly membership fee, somewhere between $20, $25, depending on the services they offer, a month per person, regardless of what happens. We share data, we set targets, and at the end of the year, we settle up if they can improve performance over what would happen to PEIA. And as you can see, we did save about $204,000 last year in this program. So it's a way to stop that churning of primary care, touch me, pay me, touch me, pay me. Pay you $21 a month, you take care of Delegate Bates, whatever he needs the next month for primary care. Lots or little. Working okay. And we have 3 more coming on in July. WVU is coming on with about 7,000 members in July. Davis is coming on with several groups, I think 6 or 7 groups, and Aledade groups. And Aledade, we already have one group. They're going to bring in another group, hoping to bring on in July. So that program is still continuing to expand. And that's just a nice chart to show you where our money goes. And here we go. I just decided I'd throw in a chart that we get standard reports. It's an ugly chart, but it's going to give you a chance to see roughly what the volumes are, what the bill charges are, and what we're paying for services in clumps, right? Here's what I want to talk to you about. Take a look at the very first line on that chart under maternity. You can see we billed $22 million. Of that $22 million that was billed, $3 million was allowed. That's 13% of bill charges. Think about it. Think about it. Now, there's reasons for this, but take a look at this chart and the next page, and you can see this is roughly what we spend money on at PEIA in big chunks, okay? Volumes and discounts. At the very bottom of the page, if you do the math, you're going to see, on average, as I said earlier, we're paying 30% of bill charges. I told you I had an out-of-state problem. You ready? I can tell you're having fun. Most of you are awake. That's a good thing. I appreciate that. So here we go. This is a comparison of in-state reimbursement to out-of-state reimbursement. So I'm going to leave you another Cheatham rule of thumb here. To go out of state of West Virginia and get services, it costs 4 times as much as doing it in the state of West Virginia. Why? Because of the Omnibus Health Care Act. I mean, you can take a look at the out-of-state providers. The providers themselves, inpatient facilities, 730% more expensive than staying in state. I've done everything that I can, waiving deductibles, waiving copays, giving free services to try to move people in state. I've even canceled contracts out of state. That's what I'm going to show you on the next page. So right now, if you go out of state under any plan, as you saw earlier on the benefit design, it's 70-30 coinsurance. If you go out of state to a contracted provider without prior authorization, it reduces to 60-40. I'm talking Plan A. It's worse on other plans. When I talk generally, I usually talk Plan A because it's got 84% of the people. All right? So there's a benefit design to encourage you not to go out of state. If you go out of state to a non-contracted provider that's not contracted at all, the benefits are not covered. There is no coverage at all. What we've done in Parkersburg and Huntington, where the facilities can do everything that can be done across the border with the same or equal quality, to keep care in state, we have canceled the contracts and taken Ashland King's Daughters out of the network and Marietta Hospital in Parkersburg out of the network. Marietta Hospital is mad as a hornet's den. I got a call from the Secretary of Administration from Ohio when we did this. We moved $4 million from Marietta Hospital to Parkersburg to WVU, Camden Clark. Now, I've got legislators that aren't happy with that. But my philosophy is that everybody that we cover in insurance has worked for, is working for, or is retired from the state of West Virginia and gets a paycheck from the state of West Virginia, from the state of West Virginia. And why should we not keep our dollars into West Virginia facilities so we can spend that money to recruit the talent we need here to take care of our people here? If you ask me to change it, I will. More choice to go to Marietta, but that's why we made the decision. I'm just letting you know. And at the time, I couldn't negotiate a good rate. They've actually agreed to take West Virginia rates at this point because they want back in the network. But you know what that's going to do to Camden Clark, so that's a discussion to have. That's that one. You see the 70-30 we've done, and then we've done 143 maximum facility fees. These are, well, I don't want to say low quality, they're low risk procedures. They're images, colonoscopies, labs. We basically said, I can go to WVU and I can get an MRI for $1,600 of the lower back. And that's reasonable even if I look at national data. And I basically said, look, that's all I'm going to pay for it. If you want to go to Winchester and get a lower back image, I'm paying $1,600. The difference between the $1,600 and the Aetna contract, that's all you. That's all you. Okay? So we've done that to also minimize that cost that's going out of network. And as I said, we've tried to waive deductibles, copays to move people in state as best we can. All right, let's talk about the big growing items, pharmacy. This is the top cost by drug, net cost. Quick snapshot of that picture. We got a lot of money in specialty drugs and a lot of diabetics. You want to slice it another way, you can look at drugs by count. What this shows you is we're all depressed, we have high blood pressure, and we need Nexium.
And I asked the question for those of you who abandoned Go 365, how much of hypertension, type 2 diabetes can be solved by lifestyle changes? I just leave you the open question. Top specialty drug costs, that's our fastest growing thing. It's going to be, they say, in about 5 years, 10 years, specialty drugs will be 50% of our drug spend. And then you can take a look at the next slide talks about our utilizers in top therapeutic classes of the ones we just talked about. Again, you take a look at diabetics up there on the front line. That shows 16,000 users as diabetics. I guarantee you we have at least 26,000. I guarantee it. I don't know where they are. It's because they're not on a drug or they're not paying attention to it, but all the data says we've got at least that many. So, specialty drugs. PEIA was one of the first, if not the first, to carve out specialty drugs from a PBM. We went out to HealthSmart and we said, build this plan this way. We want you to go out to bid individually for 400 specific drugs and get the best price by specialty drug. After doing that, we ended up in 6 specialty pharmacies to get the lowest rate we can and started to manage the pharmacy program. From there, we bid member programs. So now if you're in a specialty drug and you can qualify for a member program, which could save us $1,000, $2,000 per script, you have to apply for that specialty drug program. And you can see the spend on the right. We've saved a lot of money by this plan. We just recently went out to bid again. We're now down into 2 pharmacies, a Credo and CVS specialty pharmacy, but the program is still being managed by HealthSmart. But it's been a very successful program. It's saved a lot of money, a lot of money. And this shows you a quick run on trends. The other initiative we've taken to heart is generic fill ratio. And I want to talk about this. This one shows we're at 89%. I believe at the last report currently, we're right under 92% generic fill rate, which is tremendous. That means 92, understand what we're saying, 92% of every prescription we fill is generic. 92%. That 92% represents about 25 to 26% of our pharmacy spend. You getting that number? 92% only represents 26% of our spend. Brand name drugs and specialty drugs represent the other 75. We do a lot of things to manage the pharmacy as well. The first one is rational drug therapy. They're up in Morgantown School of Pharmacy. We have a contract with them to do all our prior authorization, step therapy for pharmacy services. They also have a program called SEMP, I think it's Safe, Effective Management, Medical Management Program. Has to do with the opioid program. We lock people with more than 50 morphine medical equivalents into one doctor, one pharmacy, and counsel the doctor. They're required to sign a contract with a doctor. So it's a nice program that's going, and we're still trying to run data on it right now, see how we're doing. I talked to you about specialty drugs. We do all kinds of other programs. We pill split. We offer free generics to let people try to move to a generic blood pressure medicine. We do this specialty couponing thing. So anyway, an idea of what we do. Next is our wellness. We do have a diabetic weight management program, 2-year, once a lifetime benefit. You do get a second try, a second attempt, and a weight management program. Both prove very successful for the people that use them and stay with them. They prove disastrous for the people that fail. We also do our Healthy Tomorrows program, which we talked about. That's part of the Go 365 you heard about in the press, right? Our Healthy Tomorrows program is still in place. It started years ago as gift cards for getting biometric screenings. Now it's designed to be get it at the doctor's office, your blood work. We cover a free wellness visit a year and free lab work to do this. And if you get your numbers within range or have a doctor's excuse of why you can't get them in range, you will avoid a $500 deductible penalty. And that's in place still today. By the way,
50 to 60,000, about 60,000 actually, people are meeting those qualifications out of our 77,000. It's been the penalty, as much as we like the term penalty, the penalty woke people up and they paid attention. Our goal last year was to put another wellness tool in place with Go365, as you know, and also put a premium penalty on this to get more people involved with lifestyle event changes. Both of those were frozen. Also, I remind you, we do have a tobacco premium differential as well. $25 single, $50 family. If you use any kind of tobacco, that is cigarettes, smokeless tobacco, or vaping is considered tobacco usage under our plan. I'd be remiss, I told you all this time, right? Don't forget about the retirees. Let's talk about Medicare retirees. Now it's time for the Humana commercial. We contract out to Humana for our Go365 plans, so for our Medicare Advantage plans, or MAPD as we call it, Medicare Advantage Prescription Drug Program. So just so you understand, because I get this question a lot as well, and I'll give you the scope of the issue. Most people think Medicare and a supplement. Humana is not Medicare and a supplement. It is really both. Our benefits that we offer our retirees are much richer than standard Medicare program, okay? So we're paying about $250 per retiree per month to Humana to supplement and make the benefits better than they would be under Medicare, right? Lower copays, lower out-of-pockets, lower in-hospital costs. So the Center for Medicare and Medicaid Services, CMS, gives Humana roughly $800 per person per month for a Medicare retiree. For a Medicare retiree, PEIA gives them $250 per person per month per retiree. So Humana has got a bucket, if I did the math right, of about $1,050 per person to spend on claims for our Medicare Advantage. And when they go to the doctor, they go to the hospital, they do whatever, Humana just pays the bill, and it's all-inclusive, one-stop shop, one ID card for drugs, medical, everything. Okay? There's no secondary coverage, there's no moving claims around, Humana just does it all. And I just told you about what it costs to do our Medicare retirees. Okay? So this shows you the year-over-year enrollment that I talked about. You see when I got here, 36,000. Now it's up over 50. And on the right side, you can see the cost over there. I said 250. It was as high as 260. It's gone down because of renegotiated contracts. It's actually about 225, but you get the idea. That's what Humana pay, what we pay Humana. We also try to take care of our lower income retirees. Two ways. Number one, the federal government has what's called low income subsidy, or LIC. Did you qualify through several stages of LICs? PEIA also offers, if you're lower than 250% of the federal poverty level, we offer an assistance program. Reduced premiums, reduced copays, and reduced out-of-pockets. It is income-based. You do have to qualify for it. There's a form you have to fill out every year that we mail to our retirees every year. And I want to tell you, we have just around 5,000 to 6,000 PEI retirees on our subsidy program. This is info for you, just what's happened over to the retirees over the last few years. And they also have clinical programs and wellness programs that I put up here for you so you know they're taking care of retirees. And I want to remind all of you that Humana retirees have had Go365 for years, and they still have Go365, and it is voluntary. And finally, let's get to the end of PEIA and the other things that we do that we're probably not here to talk about, but I just want you to know that we do it. We do contract out for the employer-paid 10,000 basic life, and we offer voluntary life products as well that we administer. We have a contract with FBMC. That used to be Flex Benefits Management Corporation, but they've changed their name to just FBMC now. They do all of our voluntary products, as you can see listed on the board. Those contracts are generally bid out every 2 years for each of those sub-products. and they're all voluntary. And if you want to know who's enrolled in what product and by what year, there you go. Finally, if you need it, at the back of your book, there's all the, well, there you go. There's the links to all of our sites and other things that we do. That is the wonderful world of PEIA as I know it. And I'm ready for any question you've got, and I did make it in almost an hour.
That was good. I thought we were going to be here 3 hours, so you made it 1. Are there any questions of the task force before I may take questions, or will take questions from other folks? Okay, we'll start with Mr. White. I saw his hand first.
Just 2 quick questions.
Could you pull the microphone closer?
Okay. I tried to keep notes here, but it's dark in here. I can't see. On page 73, under the year-end reserve history and funding, you've got that the additional funding from West Virginia in 2017 was $81.8 million. Could you I don't remember 81 million. Could you tell me how West Virginia gave an additional 81.8 million in 17 million in 17?
Well, right off the top of my head, I can't, but I do remember getting 81 million that year. That was a big year that we asked for it, and we did get it, and we raised premiums. Take a look at what we did in 17 or 18.
Okay.
I definitely, Joe, are you out there, Jessica, somewhere? Gotcha. This is Jessica Kramer, by the way. She works with me. She's going to take notes. Joe, I will get you the specific answer to that question. Did you get it? Okay, thanks.
Okay, and then my second question, then I'll leave you alone for now. We're talking about the in-state and out-of-state care, and this is something that I hear quite a bit, and maybe you can enlighten me a little bit. What about folks that need services that I'm hearing from that cannot get the care they need in West Virginia? Have we run into any of those where they can't get the services?
Sure. Like I said, we've got great relationship with Johns Hopkins. We've got relationship with University of Kentucky, and as I said, we've got an individual contract with Cleveland Clinic. They can get there. There should be no trouble.
So is the cost different for them?
It's still 70% if you go out of state. Please understand. Here's another thing you're going to hear. You forget, I told you our out-of-pockets in general are better than the public. We've got fairly low out-of-pocket. Don't get me wrong, okay? If you need to take a drug and it's costing you $500 a month because you're not on a copay, it's a third tier or some drug, I'm not saying you can afford it. That's not the message I'm giving. What I'm saying to you is we do have a $1,750 drug out-of-pocket every year. That's the most you'll pay in a 12-month period of the plan year. So there are protections for people that leave the state or get in those catastrophic situations, both on the medical and the pharmacy side.
Good, thank you.
Yes.
Hi, Amy Loring with Berkeley County. One of the things that I didn't see in here was the facility fees.
I'm having a hard time understanding you. I'm sorry.
Sorry. One of the things that I did not see in the plan description was the facility fees and how that came about and how they're being utilized.
Sure. The max facility fees was the question. How did they come about? Yeah, so we contract with a company called Healthcare Blue Book. It's a healthcare transparency tool which lets you see what everything costs, whether facilities are red, green, or yellow, whether providers are red, green, or yellow, what the average cost should be based on PEIA claims data. They model these facility fees for us based on West Virginia and national data and surrounding county data, and it's really a fun graph that shows the most expensive in bar graphs down to the cheapest. And then we put a line up there somewhere above half that makes sense. And by the way, every West Virginia facility meets the requirement. If you stay in state, you'll get no extra charge. But that's how we do it. Healthcare Blue Book models it for us based on data.
Does that answer your question?
By the way, okay. They wanted to add 24 more. And our intention was to add 24 more fees this coming July. And I guess that's in my preferred purview, even though the benefits are frozen, but we elected not to put those in place in the spirit of the freeze. So there are 24 more pending for probably July of 19 that we're going to defer.
Facilities?
Yes.
All right. Someone else have a question? Yes.
To the privatization discussion early on, you said that we already contract out, and if we contract out more, it will cost more money because those people make a profit, correct?
I believe if you privatize, you're going to have a different admin structure, a profit structure, a premium tax structure that we don't have today.
But the administrative structure that we have right now currently is low because we contract this stuff out. And you said if we didn't contract it out, then our administrative costs would go up.
No, I'm saying if you contracted out, the overall administrative cost for the plans, I believe, will go up. Yes.
Right. But if we didn't contract it out, isn't there a possibility to save money and create jobs here? If we're contracting things out and it's costing us money because they have to make a profit, could we save money by not contracting some of these things out?
That's a great question. Potentially, yes. Potentially, yes.
So you could bring the whole operation into state government and just let state employees run the entire operation.
Exactly.
Right.
I mean, the answer is, do you want us to build HealthSmart? I mean, that's what you're asking us to do. Do you want us to build HealthSmart?
Question.
And can we build it cheaper than they can?
Right.
I don't know.
Well,
Honestly, sincerely, I don't know. And it's worth looking at. But, I mean, we're not the only client that HealthSmart insures. So there are economies of scale across their platform that we won't have.
I think one of the, and I'll take questions, just comment on this privatization question because I've heard it at least 1 million times. The concept here is that a company like HealthSmart may put together a structure to deal with the nuances of paying claims and all that goes on because it's very complex. Could state government do what HealthSmart does? And, you know, you're going to get one well of a conversation about that. But PEIA itself is basically almost privatized in the sense that it's contracted out to all these private companies that do this and do that. And so for those who argue for privatization, it's almost there. You've got, what, 50 employees that are PEIA employees. So, you know, if you know, you can have a conversation about whether or not you would get rid of the HealthSmarts and the CVSs and the different ones, bring all what they do inside of state government. But I think, you know, and I'm not going to prejudice the outcome, but how many states do that?
I don't know the answer to that.
Okay.
I would tell you,
Sorry.
you know, we are out to bid. All these products are out to bid
Every one of
on a
them.
reasonable basis, and we are taking, hopefully, best in class, lowest in cost to do this. And I'm not sure that you're going to get a lot of economies of scale to compete with that. But the answer to your question is yes, we could do that. We could buy a claim system. We could update that claim system. We could keep it updated year to year and try to run an operation for 200,000 people, which I don't sure that's a good economy of scale, but we could. The answer is yes. Let me tell you the other things. Well, I just fired off a thought, if you don't mind. There's money to be saved at PEIA. So, and let me give you a couple. I mean, there's money to be saved. It goes back to my out-of-state comment. We could, for example, we could mandate mail order. We mandated 90-day fills, and the pharmacies yelled at us. You've been there. You guys have heard pharmacy comments. We mandated 90-day fill, and we required the local pharmacies to take our current mail order rate with CVS. So there's no differential between, but the pharmacy network cut in half to take that 90-day retail maintenance fill because a lot of local pharmacies don't want to take it. How much money do you want to take out of your mom and pop drugstores? That one drugstore that's sitting up there in Pocahontas County, for example. That's the question. I'm saying there's money. There's a couple of $1 million. But the pharmacies aren't going to like it. I mean, that's one thing, for example, that we could do And is it worth that for the other economic ramifications of what that does to the business structure in West Virginia? I don't know. But there are ways like that around.
Dale Lee?
Well, that happens to be one of my questions that I have. And
Well, there's your answer.
I have three.
Okay.
We have the 90-day requirement for the prescription drugs, but there are some drugs where you may not need them every day. Is there some savings that could be done on are there some drugs that you could do a 30-day supply knowing that you may not need that drug each and every day?
I don't know why in that case the provider couldn't provide 10 drugs a month for 90 days.
Okay. And what would happen if we increase the pool, with a younger, more healthy population, so to speak? I know the costs go down, right?
Yes, if you generated the same revenue, if you get a younger population, we're salary-based. If you get a younger population, I would assume that they would be making a lower salary structure, so they'd be on the lower end of the premium scale. But if they didn't have any claims and they paid premium, yes, that would be of a benefit.
So the question, how do we compare them with a model like a Massachusetts model where they opened up the pool? Do you have any comparisons on that?
I do not.
Can we get comparisons on that?
If
I don't
you
understand
will,
the question. Are they allowing people to participate in their state health plan?
They're allowing a lot more people to participate
that aren't
in the
state
plan.
employees.
Right.
So private sector people could join the plan.
Yeah.
so this.
Well, I guarantee you that a lot of them would.
Well, I understand that, but,
Yeah.
but we have to look at a cost analysis of that. And that's what I want to do some type of comparison on, how they did theirs.
Well,
and
let me
what that
speculate
cost.
on it, not to dominate the conversation, but since you can't underwrite the risk, then, the tendency when you open up something would be the less healthy would get there first.
I understand that.
So, whatever their age, but obviously you could expand the pool. There are some companies that come in the door, correct me if I'm wrong, Ted, but there are large providers of health care insurance around the United States whose pool is in the far beyond our 230,000, who come and argue that let us take over PEIA and we'll put you into a pool of 20 million people rather than 230,000, then that'll save you money. So there's another way to skin that cat. And I'm sure that as the Plan Design Committee meets, they're going to hear from those types of folks that are going to walk in the door and say that. They've walked into my door and said it. And so there's different ways to expand the pool, but you could. We do sell PEIA. Well, you talked about non-state agencies. There was a proposal, it didn't go anywhere, to make this a small group offering to the private sector, wasn't there, 3 or 4 years ago?
There was.
So you can do it.
And then my final question, Ted, is many of our border counties, it's much easier to go Eastern Panhandle, for example. So how many out-of-state providers, like Winchester, how many out-of-state providers do we have that accept the state
Rates?
rates? Yeah.
We do have a lot of border county physician groups that accept PEIA rates. We have a couple of surgical centers, for example, the one, Seven Gables in Huntington, accepts PEIA rates. Winchester, I don't think that Valley Health Medical Group or the hospital itself up there accepts PEIA rates. They're on an Aetna contract. I was on a conversation with Winchester 2 weeks ago trying to see if we could do something about these max facility fees, at least get them to honor those so that we're not balance billing our members. And we're going to schedule another call next month, but I don't know that I'll have a lot of luck, but I'm trying.
But I believe I heard you say, though, that in Ashland and Marietta, that by taking those out of the equation, now they're trying to get back into the equation by saying they will accept what we do, right?
Anecdotally, I've heard they might be willing to take our rates, yes. Our rates, yes.
Okay.
In just Marietta.
Okay. All right. Thank you.
Okay, Lisa first, then we'll go back to you. Okay.
First of all, good job. From a bean counter perspective, good job. Just on the out-of-state, just to be aware, and maybe you already are on it, just to make sure that we handle, if we're changing out-of-state, psychiatric coverage is big on certain border cities, so sometimes you may have to have coverage right over a border. For the state of Ohio does not allow psychiatric to come into West Virginia on the Medicaid side, so we have to just be aware of that. Humana, just for a comment where we were talking about maybe what the providers think of PEIA as a payer. Humana, and for maybe Joe can speak as well, Humana is, people cringe from a payer perspective when they hear about Humana. So it's one to process claims is very difficult, pre-authorization. So if you're paying them that per member per month, just maybe do an inquiry of some of the providers on what they feel that they're getting from Humana. And then lastly, do we require a high-cost claimant? Is it mandatory that their claims and spenders managed by PEIA? Oh,
that's a great question. Boy, I tell you, that's a great question. This was one of the intents of Go 365, was to work on a point structure to incentivize people to get into case management, and additionally subject them to the same penalty of $25 a month premium if they did not engage with case management if they needed to. That was definitely in the cards for discussion when we roll that out. It's not off the table, but at the moment we're frozen, so we're not going to do that, but that is definitely something I think should be on the cards for the next time we make a plan change. Absolutely, that's a very valid point. I mean, we have people that will generate $80,000 in claims a year and have never seen a primary care physician, ever. Yep.
I also wanted to elaborate on my question earlier, but also to speak to Mr. Lee's question as well with the bordering counties. There are a lot of facilities that are bordering Berkeley County and Jefferson County that do not accept the coverage for certain procedures, quite a lot of common procedures. And the fair price, I think everybody here needs to understand how that works and what that looks like, is that if the cost for a certain procedure goes beyond what is considered this fair price, then the employee is paying for that additional cost. So on top of whatever their copay may be or what their deductible, they are looking at a significant cost compared to what the plan description may look like. So that is something that I think that we need to be aware of and something that we need to discuss further.
Agreed. Yeah, so I think what I heard was you're talking about the max facility fee in the outside areas, and that you're concerned about people having to pay that balance.
Correct, and also in the state, Jefferson Hospital actually is above the fair price in a lot of procedures. So I'm not sure what those residents are doing for their health, their procedures that they're having. But I know between, Berkeley does. Isn't within the fair price for quite a significant amount of procedures, but Jefferson is actually out of the fair price range. So I'm not sure how that's going to be addressed.
The key here that we want that we don't have is we really do want, and ultimately I want to get to a plan where people want to pay attention and make a decision to manage their health care. It goes to that issue. The simplest one I can give you that everybody knows, when you go to the dentist, they want to give you an X-ray. When you go to the dentist, they want to give you an X-ray. I'm telling you don't need an X-ray. And the dentist goes, well, it's covered by your insurance. And the answer is, sure, it's covered by my insurance, but I don't need it, and if I get it, it goes to my premium, and next year my premium is going to go up. It's a cyclical thing. I mean, ultimately, I want people to shop and realize in the Eastern Panhandle that yes, they are going to have to drive 20 minutes past a gorgeous facility called Winchester Medical Center, and it is a gorgeous facility and a well-run facility, to go up into the Panhandle to get their colonoscopy done. because it's going to save the plan, it's going to save them, and there's not going to be a difference in outcome. And I'm sorry, I'm on the mantra. I want people to be educated consumers. And the other thing that we need to do, and this is my conversation with Winchester, is asking them the question, why do you think you're worth $3,500 when all the surrounding hospitals are charging $2,000 or less? That's the other piece of this for the pushback. Is it really worth it? You know. So sorry, I got on a soapbox, and I didn't mean to. I'm trying to be factual. I got on a soapbox.
We're very well aware of this Eastern Panhandle discussion, but it's good that we're having it.
Yeah, we could go on for quite a while.
And the other thing is, and honestly, we've talked about this, about building an Eastern Panhandle plan. There is an issue in the Eastern Panhandle, I agree. Let's build one. I can build anything you want in the Eastern Panhandle. How much would you like me to raise your taxes? Or how much would you like me to raise their premium to support that plan of benefits? Again, you just see, I keep 3% for admin, and everything I get in, somebody goes to the hospital, I pay a claim. This is a truly dollars and cents issue. I can build whatever you want. So when the task force comes back and says, let's take care of the Eastern Panhandle and give them a 90% plan, first dollar coverage without a deductible, I can build that for you. And I can tell you what it's going to cost.
Yeah.
That's fine.
Okay,
Thank you, Mr. Chairman. Ted, you keep bringing up Go 365, and I understand your goal, particularly with the situation of health in West Virginia. But there's a difference between incentive to do something and punishment to do something. And I just wonder if you really, obviously you want this program. You've mentioned it several times.
Not anymore. Not
well,
anymore.
I have to tell you that I believe, and I always said that I didn't know much, except I know how teachers think. I believe that your punishment for not participating correctly in Go 65 caused a 9-day strike.
Okay.
Well, it ended as soon as it was asked to be ended, very early. Because I called him the day I met with the folks from the representatives of the unions, and it ended that day. So I called Mr. Cheatham that day, and I said, we're going to have to reverse course on it. So just for the record, he did it immediately.
We have terminated the contract with Go 365. It's been terminated.
It's actually the contract with 365 is no more.
Right.
Partially because of the objections, and partially because it's a taxable event if you have, if you earn something, which ends up on box 13, I think, on your W-2 with the amount. So administratively, it ended up maybe being more of a burden than it was worth in that sense.
Right.
So, but he's, in his defense, I think he's stating that that as a part of the discussion, whatever you call it, some sort of wellness strategy where people participate in their own health care by shopping, to me, is a meritorious goal. Maybe it was, you know, the name and whatever, as we all know, did cause a lot of confusion, but all health care plans are heading that direction, or else we're just going to keep paying higher premiums because nobody tries to shop or do wellness.
Yep.
So is there some,
by the way, Go 365 for the task force members, if it comes up in your public hearing. Contracts ends the end of April, and letters should be going out shortly telling people that they can have to the end of April to spend any money that they have earned, because we don't want to take that away from them through the end of April. And an email has already gone out to everybody, so they should have it already, but we're also going to send a letter, just be safe.
Delegate Bates.
Thank you, Mr. Hall. Mr. Cheatham, I appreciate your presentation. I think we all now have a better understanding of the complexity of these issues. I thank you for your presentation. I think we all have a better understanding now of the complexity of these issues. and we hear about fixing and funding, and I think you've said that you can, we tell you what to do, you could come up with a fix. If it's, you know, it's a funding issue. If we throw enough money at this problem, then there is a way to potentially be able to have whatever plan we would choose to have. I think I've heard you say before, it takes about $50 million year over year. $50 million the first year, $100 million the next year, $150 million the next year, $200 million the next year, to basically keep benefit levels at their current rate. We're frozen now. Can you tell me what you think the 4 primary drivers of that cost increase is each year? What 4 or 5 things drive that? Well, maybe it's 2. What causes that $50 million of additional spend year over year? What's driving the cost aspect of this?
Yeah, the biggest driver by far right now is pharmacy expenses. We're one of 2 states in the nation that let the manufacturers set whatever price they want for whatever reason they want on drugs. Not a state problem, it's a national problem. The rebate system that's set up in this country for drugs is just terrible. It causes drugs to be inflated more than they need to be. Drugs are going up at double-digit inflation. They have been for the last 3 or 4 years. And there is not, other than plan design, a way to stem that tide. I mean, we keep getting, you know, listen, I got, what, 220 million in drug spend, something like that we just showed you. I'm getting back rebates of $50 to $60 million. That's what's keeping our inflation quote at 2 to 3% on the drug side. They're just raising the drugs 10% every year, and then they increase my rebate by 3 or 4%. They're still spreading out that gain. It's a net. So drugs are a huge problem. The rest of medical inflation is just prices are slowly creeping up over time. We had a big jump when ICD-10s came out. You all probably remember that. All of a sudden, this is a true story, our emergency room almost doubled. And we kept looking, why is our emergency room going up? We can't have people going to the emergency room. Well, ICD-10 came up with another code of a different intensity at like double the rate of the normal ER code, and every visit was billed at that higher code. It just became a billing issue. There's a lot of things facing the cost, but the costs are just going up slowly. Utilization is a little bit sometimes. People goes up. That depends on the year. But drugs is a big one.
So primarily pharmacy costs.
Yeah.
Thank you.
Dr. Gupta.
Thank you. I wanted to just add that, you know, if we look at this from a pure financial standpoint, there's 3 or 4 different strategies you can adopt. Obviously, you talked about providers, cutting provider payments, cutting benefits, revenue generation, or changes to plan. And we've been talking about plan, and we've been talking about that. But I think going back to Delegate Bates' question is, I mean, you got to keep asking why. So why is the pharmacy cost going up? We do have the #1 highest number of prescriptions in the country, but why is that? About 21 prescriptions per person per West Virginian in the country, actually, in the state. And the reason for that, it comes back to, I would say, those chronic diseases. I mean, you've got a lot of, if you look at it overall, and that's what the wellness strategy and the prevention strategy have to be very critical part of the whole discussion. It goes back to diabetes, high blood pressure, stroke, cancer, in addition to the opioid issue. And these are, again, preventable diseases. We don't want to get to the stage of getting people on 21 different prescriptions. Then, you know, 10 of those are generic, and then 11 of those are brand name, and they're busting your budget with the 75% of those costs. So I think it's very important to consider the prevention aspect, and a lot of what you've already discussed, and how do we get people, it is somewhat of a culture change, and it has to be driven. Studies have shown, again, that when you put dollars to it and have people talk about it with people, with it well informed, with the change in behavior over time, it does tend to work out. But I don't think we're just going to be able to spend our way out of this. I think it's very important to think about strategies that will help people change over time to reduce the number of prescriptions and to get healthy.
All right, I guess it was a comment. Do you have a response? Okay, thank you. Are there other? Yes.
Thank you, Ted. Thank you. Great presentation. Can you provide for us a listing of claims data as it relates to diagnosis? Well, I'm interested in looking at it that way in terms of, I mean, I know we see that you all have programs related to diabetes, but I'm interested to know of the population, you know, I know we've got a high incidence of heart disease, chronic heart disease, diabetes, overweight, hypertension, et cetera. But I'd like to see the actual claims data as it relates to what are our cost drivers
Sure,
and associated
we can do
costs.
that. Let me caveat the data you're going to get. We could probably do more depending on how deep you want to go. We typically run data off 3 initial diagnosis codes at the moment in our warehouse. We can get down to 10 if they're coded. So the issue becomes, you may come into your doctor and your first diagnosis is diabetes. So we're going to pay on diabetes even though you've got secondary of depression, hypertension. Those may not get picked up on what you would see as our normal data house run, because we've typically run off the first diagnosis. Would the first diagnosis be okay, or do you want us to move down for you and try to pull some more? Where do you want me to go?
More than one.
More than one?
Yeah, and perhaps you have folks that would know what the cutoff would
Okay.
be. But I would say that the top 3, for example.
Okay,
Because,
that's why I was asking the question.
because in most instances, you've got you're obese, you've got high blood pressure, et cetera,
Right.
et cetera. So
Yes, we can do that for you.
thank you.
Got that?
I suppose you can get that to everybody on the task force.
Yes.
And we'll be able to do that. Electronic staff will do that. We'll talk about that once we're done here about how we're disseminating information. You have another question?
Yeah, I just have one more question for Ted. Going back to what Christine was saying about the Health Smart and the possibility of maybe looking at that in state. What I know that there are times that we duplicate notifications. For example, in the open enrollment period, we have to let you know if there are any changes, and if we say no changes, then Health Smart turns around and may deny a benefit or delay a benefit unless you also notify them that you don't have any additional coinsurance or anything like that. So what kind of duplication of notifications are we doing, and is there some cost to that too?
Well, there may be. I'm not sure. I sure hope we are avoiding duplication. That coordination of insurance, it's a once-a-year thing for us. It happens in open enrollment. It should transfer to Health Smart. Mine didn't this year.
Mine didn't either.
No. So, as a matter of fact, we're working on that right now because mine didn't. And I asked that question: Why are you sending me this letter? So something happened in a file or something happened in a procedure that it didn't get picked up. But yeah, if you find anything like that, by all means, we want to make this as best of service we can provide.
Right, and it should be streamlined where they should pick it up. I understand
Yep.
that is the goal. The easier we can make this for the participants, the better it's going to be, and that should be a real simple type of fix, shouldn't it?
I agree, and we're working on that one
Okay,
specifically.
thank you.
But on the second side of it, you definitely do want us to make sure that somebody doesn't have other insurance first before we pay. So,
I don't disagree with
double-edged sword. Yep.
I don't disagree with that.
All right, we got a little more time here. So, Mr. White.
Thank you, Mr. Chairman. I promise I'll be quick with this, but I made a promise to this lady, and I'm going to have to keep my promise. But I just got, Mr. Cheatham, I got one more question, and then I received this. I got about 15 emails here, but I'm just going to give them to you 2 at a time over the meeting dates. Is PEIA charging certain patients an extra copay on top of the copay that they're paying? This lady says that she was informed by her doctor that PEIA is requiring certain patients to sign a paper saying that they are informed officially that PEIA is charging certain patients an extra $20 copay on top of the copay already. Is it? I've been looking on the slide. I did not see this.
The only exception I can think of that may happen, that I know of that we sanction at PEIA, is if a clinic wants to conduct a telehealth visit to a remote telehealth facility. For example, Cabin Creek wants to have a telehealth visit for an orthopedic surgeon in Morgantown, and they want to facilitate that call from their clinic with their equipment. We do not, we'll pay the provider at the other end to do it as a normal office visit. We do not pay a sender fee payment for the clinic. And we have said to those clinics that have asked, if you want to charge a copay of $10 or $20 for setting up this, because it's all at the member's expense, because the member's not driving, the member's getting their services remotely, and we're going to cover the visit cost, you can charge that. That is the only thing I could think of that anybody would get an additional copay assigned to them off the top of my head.
Okay. And then this, Mr. Chairman, if, I'm going to leave this. I've got a copy of a letter. All of us received this letter by email. I received it 2 or 3 times. I responded to the lady. I think Mr. Spencer responded to the lady. And I do know that because I received an email about a HIPAA violation, I've taken the lady's name out, even though she sent it to all of us. She has a very big problem getting her medicine. She's got MS, and her medicine is usually a couple weeks late by the time she gets it. I promised her that I would present this letter to each of you. She did send it to all of us, I'm sure, and she may not have. I
don't have it.
But I've got a copy of it. I want to leave it with you. I promised her, and I want to keep my word that I would give you this letter. Thank you, Mr. Chairman.
On the telemedicine question, I know this has been asked of me, so I ask you, and we can clear the deck on it. There are telemedicine providers that believe that the copay charge, what is it now, $30 or something to do a telemedicine?
40.
40?
That's for what I call primary care telemedicine. The rest of the telemedicine copays would be also 40 for a specialist, for example. Yeah, 40.
Here's the question that I'm asked. That the utilization of telemedicine in the PEIA plan is extremely low. It's below 1% or something.
About 30 to 40 a month.
And the allegation is, or the statement is, and I don't have any way to prove it, but there are people in this room that probably can argue about it, that other plans' utilization for telemedicine is 6%, and that we are low, and part of it is this $40 copay. Do you want to address it? Because apparently in other health plans, maybe there is no copay because there's an incentive. Get on telemedicine and, you know, it saves the plan money. So do you want to address that?
Sure. We have always been under a primary care supporting plan. We are very advocates of people picking a primary care and going to that primary care for wellness. That's been the incentive of all of our wellness programs. We don't want to undermine the primary care model. However, we do realize after hours late, people may need to talk to a doctor, and we felt it's good to have primary care or telemedicine. So we initially priced it. Our urgent care is $50. Our emergency room is $100 copay. So we tried to take telemedicine below urgent care to give people an incentive to at least go to urgent care. The best answer is to call your primary care physician instead of telemed. That's the best solution. But if you can't, call telemedicine. Now, even though we're frozen, I do have some flexibility under the code, and I've already reduced the telehealth copay to $30 starting this July 1st to continue to run more data, see what that does with access, see if that changes anything. We're also looking at the telehealth data to see how effective it has been. Has it really diverted those urgent cares? And I would tell you, I don't want to cite the number, the first set of data I looked at, there were still 20 to 30 people, as I recall, that ended up in an urgent care even after they'd done a telehealth visit. So we've just got to look at the data. But I will tell you, primary care visits are down, telehealth visits are up. So we're going to lower it to $30 July 1st and continue to run the data to look.
All right, thank you for your candid answer. And I think the people who are interested in that question, you've given them an answer they may or may not like, but you've given them the answer.
That's correct.
Yes, Mr. McDonald.
Ted, can I just clarify telemedicine, telehealth? Are you talking a telemedicine benefit where I can call directly as a insured to call Dr. Ted and say, this is my issue, and is there a mechanism there? Or is it that only when I go to my primary physician or even a hospital and I've got a complicating condition that they're not comfortable with, and the physician says, maybe I better call telehealth medicine at Marshall or WVU
Right.
or whatever. What are the options available in telemedicine?
Both are available, Joe. Okay. So the first one is just normal routine operation of telehealth services between hospitals and high-end facilities like you're talking about. We recently went out to bid, February of 17, we went out to bid. iSelectMD won the bid for telehealth services, what I call primary telehealth services. And that's all we're doing with them right now. We're talking about mental health, potentially on telemed, but haven't turned on the switch yet. But we're doing primary care so that if you are just sick on a Saturday morning and you don't want to go to urgent care, you can pick up the phone and call a telehealth doctor directly. And they do routine urinary tract infections, colds and flu. 80% of their visits involve a prescription, which, by the way, I don't know that we agree with. That's another thing about telemedicine, but we're looking at it. So with both.
So the copay on that incident where I call Dr. X and he writes a script or she writes a script, what's the copay for that?
$40.
Okay. And then the copay between provider to provider,
Is
so you were
regular,
talking about a second possible copay?
Yeah, it's a regular office copay, whatever it would be, and
Okay.
typically a specialist copay is also $40.
Okay. So it's just
About the
coincidence that the numbers are the same, but it's a copay for two different things.
Correct.
Two different copays for two different things.
Correct.
Thank you.
All right, are there others? Looking around the room. Good. All right, I don't see anybody. Okay. I'll give it one more look. Well, I thank you all for your attention. Obviously, this is a lot of information, but I believe that your questions have indicated that there are parts of it that, or all of it that can be utilized as we go out to listen to the public and to listen to emails and letters like you have heard. And what we're going, obviously I've already announced, but I'll say it again, that the Public Outreach Committee will meet Thursday, April 19th at 2 p.m. in the Governor's Cabinet and Conference Room over, I think most of you know where that is, over in the Capitol Complex. Again, we thank Director Cheatham for his presentation today. Is there any other business? I assume there's probably none to come before the committee. If not, the next meeting is to be announced. We're going to see how the public forums go, and as we go forward and we begin to gather the data, the other two subcommittees will announce their meetings and inform you all as to when those are. We'll announce our next full task force meeting. I would say that all this that was done today was recorded and streamed, and we intend to do that as much as we can, including the public meetings that we do, so to be very open to the public, this process, as we try to, hear people's concerns about PEIA and what to do about it. So if there's, yes? Under other business? Yeah.
Just on the communication piece,
yes.
If we could get things, maybe the subcommittees could have kind of a Google Doc or something to try to identify when we can best meet together.
Okay.
And get some earlier communication.
I'm not familiar with that, but I think the people that I work with are. So you're right. We'll do what we can to make sure that we don't announce a meeting time
at the meetings.
That's right. That we don't want to make it so. We want to try to garner the information from the different committees as to when the folks can meet. We don't want to call a meeting and only 3 people can come. So we'll do that.
Thank you.
Okay. Any other questions? A process question like that? If not, I'll take a motion to adjourn. So moved. It's been moved. It's been seconded. All in favor say aye. Aye. Opposed the same. The ayes have it. We're adjourned.